Strasbourg. This is Steve Moran, and to my left is Dr. Markovici, and to my right is Dr. Taleb, and we'll be hosting this session, this seasonal risk forum on ulnar-sided wrist pain. I would encourage all of you that are participating online to send us your questions. You can ask us your questions through the website, and we'll be able to have you interact with us here. And to get things started, I'll turn it over to Dr. Markovici.
We are very honored to have you with us, and you will speak about ECU disorders and mistaken diagnosis.
Thank you, Lucien. So we'll talk about ECU disorders and ECU tenoscopy. I have no conflicts to disclosure. So my name is Ricardo Kempf. I'm a hand surgeon from the south of Brazil. I live in Porto Alegre. And you already know that ulnar wrist pain, it's a common complaint of many disorders. ECU, extensor carpi ulnaris, and FCU, flexor carpi ulnaris tendinitis, pisotracheal osteoarthritis, TFCC lesions, ulnar impaction syndrome, DRUJ lesion and instability, lunotracheal ligament lesions. Let's start with this clinical case. A woman, 69 years old, with ulnar wrist pain without trauma. You can see in the X-ray some kind of degeneration, but when you ask for a CT and a MRI, you can see the ulnar heads, it's a little unstable dorsally, and in the MRI, you can see the ECU lesion. Years ago, we did this kind of treatment. You see a large dorsal approach and a complete rupture of the ECU, and you make a treatment with a tenoplasty and a stabilization with the 6 compartment. The patient doing well, but the time that the recovery was 6 months. So after 6 months, she recovered a good function. And in the MRI, you can see a good extensor carpi ulnaris too. So this clinical case shows us how important is the ECU tendon for the DRUJ stability and function, and recover us about the four-leaf clover theory that Kakar and Garcia Elias published. And send us another huge message that in our procedures in our course like this that you have here in Strasbourg, that you must pay attention not only for the interarticular extruders, but the extra-articular too, like ECU tendon. So most of our books and papers only show us about the interarticular procedures and pathologies. And I think it's time to look outside of the box, that the box concept that Gregory Bay showed us about the portals that you can see inside the wrist. You must pay attention now for the outside of this kind of box. And here an example, a woman with 42 years old with a standard tendon intratendinous ganglion cyst. And we treat with a scope. We put a scope, only one portal, and a needle to enlarge the space, and we treat this intratendinous cyst with only one portal and shaver and a scope. So which is tenoscopy? Tenoscopy is a kind of endoscopy approach of tendon sheath. So you put the scope inside the compartment. And it's already described for ankle, shoulder, elbow, and wrist and hand. Here, one of the first papers published about this topic. It's in 2019. It's they put a shaver for one side and a scope for the other side in the 6 compartment, but they gave us a few tips or a few guides and rules how you can treat that. 1 year later, Fernando Corellas and his team published this paper, show us how you can find and treat the 6 compartment, the ECU compartment, through the arthroscopy. So they did the arthroscopy, radiocarpal arthroscopy, and for the arthroscopy for intra-articular, you can find and treat the ECU pathologies, the ECUs, the 6 compartment. So after read this paper from Corella in an arthroscopy course like this, I talked to him and his group to start to learn more about the tenoscopy, about the ECU tenoscopy. So you have a lot of questions how to do it, how to do ECU tenoscopy, which pathologies we can treat with this, and when you can use it. So we start at the beginning. We start with anatomy. For doing endoscopy or arthroscopy, you must to do the triangulations. So you must know which structure it in risk for do this procedure. So in the ulnar side of the wrist, you know that the dorsal branch of the ulnar nerve, it's at risk to do some kind of extra portals. So we start doing this first paper with 15 anatomical fresh cadaver, and you see the relationship of these new portals for the 6th compartment and the risk for lesion of this dorsal branch of the ulnar nerve. So we marked the 6R portal with a regular portal, and we did 2 distal portals and 2 proximal portals, and the relationship, and measure the relationship with the ulnar nerve and the dorsal branch. And here the measuring, and we did that in the 15 cadavers. And here the results. We found that the more proximal portal are safer, and the distal portal is very close for this kind of lesion in the dorsal branch. So we describe the 3 zones about the danger for damage of the dorsal branch. The red zone is distal, it's very dangerous. In the same level of the 6R, it's the yellow zone with the moderate risk. And the green zone is proximal, and it's safe for the lesion of the ulnar nerve and the dorsal branch. So we published a few months ago this paper in the Journal of Hand Surgery American. So we already know how to do the arthroscopy, how to do these new portals for the 6th compartment. You must discover when you can use it, how a diagnosis in the ulnar wrist pain, in the synovitis of the ECU, in the ganglion seats of that region, instability of the ECU, and the ECU rupture. So we start with the more frequent and more easy to treat the patient that only have inflammatory disease in the extra-articular compartment. So the patient that have inflammatory that do not improve with the conservative treatment, but only in the extra-articular compartment. And you publish this series with eight patients. So here the article that we publish in the RICMA magazine, the magazine from Spanish Society. And here the video that I did from this presentation that show us a typical patients that we treat with this kind of treatment of tenoscopy. So, years old with swelling and pain in the dorsal ulnar side of the joint. So we start with the Corella procedure with the radiocarpal arthroscopy. So you find the 6th compartment, we open it, and so you made a proximal portal and with a needle, and after that you put a shaver in this proximal portal and you can clean it all 6 compartments. Here the visions, and you can change the portals with the scope and the shaver. Here the difference between both sides, so you can clean all inflammatory disease with this procedure. Here another patient with the same pathology. So you only make three portals: the radial portal 3, 4, and 6R, and the proximal ECU portal. And here the image of these other patients with a huge inflammatory disease, with like a cyst, an inflammatory disease that make pressure and pain in this patient. So your next step is describe the technique in few patients treated with tendon lesions, partial and complete, and ECU instability. So in conclusion, the ECU tendon is an important component of DRJ, and ECU tenoscopy allows us to complete tendon evaluation and tenosynovectomy with the retinaculum preservation, and it's a minimal invasive approach with less scar and few postoperative pain with good cosmetic results. Thank you very much.
Next, Anders Surd is going to present a 20-year experience in TFCC peripheral tears.
Well, thank you for the invitation and for the opportunity to present the results of TFCC peripheral tear treatment from Norway. I don't have anything to disclose related to this, so talking about the anatomy, the DRJ allows for movement of the forearm and the wrist without interfering with the grasping function of the hand. And as we know, there is only 20% of the stability that is provided by the articular contact. The sigmoid notch may have a variety of shapes, with the flat face and C-type are the most common. The sigmoid notch is shallow, and the radius of the notch does not match the radius of the ulnar head, explaining the limited stability of the DRJ. This difference is in radius between the notch and the ulnar head does also mean there is not only rotation of the radius around the ulna, but also translation in the arm as it moves from supination to pronation. The TFCC is the most important stabilizer of the DRJ and consists of the proximal radio-ulnar ligaments with a foveal insertion on the ulna and the distal radio-ulnar ligaments inserting on the ulnar styloid. In full pronation and supination, only a small portion of the ulnar head is articulating with the sigmoid notch, and this explains how most of the stability is depending on the deep fibers of the DRJ. However, the compressive forces over the articulation increases as the forearm rotates either way. The blood supply of the TFCC is important to remember, as the peripheral part is well vascularized, ensuring there's a healing potential for repair of peripheral tears. Over the years, our understanding of biomechanics and functional anatomy has evolved, including the concept of tensegrity and the hammer concept describing the stabilizing function of the radio-ulnar ligaments. And over time, things tend to develop, and the advances in wrist arthroscopy has provided new understanding of the anatomy, classification of injuries, and guidance to treatment. The iceberg concept by Atsai points out the important function of the TFCC. It's an important shock stabilizer, load distributor, and contributes to this went fast to carpal stability as the main static stabilizer of the DRJ. So injuries of the TFCC typically appear falling on an outstretched wrist injury or a violent traction or twist. A variety of injury patterns are possible depending on the magnitude and the direction of the forces. Degenerative tear and wear may also cause TFCC lesions, more common in patients with a positive ulnar variance. So patients with a TFCC tear present ulnar-sided wrist pain, reduced grip strength, clicking, and pain or discomfort, all contributing to a reduced hand function. Clinical assessment of the DRJ includes general exam of the wrist and hand, foveal sign for ulnar pain specific for TFCC, pathology with high grade of sensitivity and specificity. Increased laxity and soft endpoints are indicative of DRJ and possibly TFCC pathology. And a piano key sign is positive if the ulna translates volarly as the patient applies pressure to the hand resting on the table. Positive test indicates there's an instability of the distal radio ulnar joint. So the usefulness of MRI to evaluate TFCC pathology is uncertain, but imaging is important to rule out other causes of ulnar-sided wrist pain or pathology that might affect the outcome of TFCC repair or reconstruction. So ultrasound in 4D CT may give a dynamic presentation, dynamic evaluation, and stress provocation and pronation and supination may reveal DRUJ instability. However, wrist arthroscopy remains the gold standard for assessment of the TFCC. So while the imaging presents a shadow of reality, arthroscopy will present the real picture and help your surgical decision making for these patients. So regarding classification, the Palmer classification distinguishes between the traumatic and degenerative lesions and subcategorized based on location of the lesion, either if it's a central tear or a peripheral detachment of the capsule, a rupture of the volar ulnocarpal ligaments, or a radial detachment. So Atsai published this paper in 2009, emphasizing the importance of the proximal insertion of the radial ulnar ligaments, and it's important for DRUJ stability. So this classification of Palmer type 1B injuries was further refined and published in 2011, and suggesting a treatment algorithm based on an extensive evaluation of the TFCC complex. So first, a clinical exam to assess the DRUJ stability based on the Ballotman test and piano key sign. And second, a radiographic evaluation to determine the presence of a location of ulnostellar fracture to determine how this may affect the stability of the DRJ and should be addressed. Third, the gold standard arthroscopy to assess the appearance of the distal TFCC and the tension of the proximal foveal insertion and cartilage stages of the joint, using the trampoline test and the hook test. So putting this together, there's on this extensive evaluation, the classification suggests a treatment for the patient based on which includes both non-operative and operative treatment options. So in 1999, this paper from Haugstvedt and Husby was published. 20 patients undergone arthroscopic repair for Palmer type 1B injury with a mean 18 months time from injury to surgery and about 2 years follow-up. They were all treated with a suture technique to repair peripheral tears, suture placed with the needles and withdrawn with the grasper, and everything tightened up to restore the tautness and the stability of the TFCC as shown in this video, as many of you have done in the lab these couple of days, tightening everything up and re-establish the suture, and then we can evaluate the trampoline test and the hook test, and the TFCC is stable and reattached. So this is a good start. What are the outcomes for the patients? So at 2 years follow-up, 14 of the 20 patients presented Mayo risk score good or better. Range of motion was almost normal except for the flexion. Grip strength were about 80% of the contralateral side, and patients reported satisfactory pain relief, and 17 of 20 patients would have redone the surgery knowing the outcome. So the conclusion for this paper is threefold. Patients with chronic wrist pain should be offered wrist arthroscopy, as it's the gold standard for assessment of the TFCC, and if a peripheral tear is detected, it should be repaired rather arthroscopically than open is recommended, as it's less traumatic and provides comparable functional outcomes. So in 2016, we published a long-term follow-up of the same patient sample. After 20 years, we were able to include 11 of the initial 20 patients in the long-term follow-up. So comparing the baseline data of the patients available for those two studies, who were available for the first and second, we didn't find any significant differences in demographic data or functional outcomes from the first follow-up. So the patients, including long-term follow-up, presented good range of motion at first follow-up. Grip strength was somewhat reduced, but median Mayo risk scores were 85, which is good. So the functional outcomes persisted over time, except for somewhat reduced ulnar deviation. The patient scored 85 as a median, according to Mayo risk score. 7 of 11 were good or better. DASH and PRWHE were low, and subjective outcomes were good, as 9 of 11 reported improve in pain scores with a median 25. Satisfaction was reported high, and most patients would have redone the surgery. So looking at the Mayo risk score for these 11 patients, including long-term follow-up, there were 8 out of 11 scored good or excellent to first follow-up, At the long-term follow-up at 20 years, 7 of the 11 patients scored good or better. And looking at how they performed over time, most patients had remaining good results, but 3 patients present with lower scores, including patient number 10 who presented at 20 years with a unstable, painful GIUJ, and she has later undergone implantation of a semi-constructed arthroplasty. Patient number 5 had symptomatic CMC1 arthritis, which could possibly affect the score as well. So in 97, this follow-up of about 3 years, patient had normal In this follow-up at about 3 years, patient had normal range of motion and grip strength at about 75% of the opposite side. 2 patients had ulnar nerve symptoms where they found 42 or 45 patients had satisfactory functional outcomes, returning to previous level of sport or work activity. In another study, 37 patients had undergone arthroscopic treatment for isolated peripheral TFCC tears were evaluated at about 2 years. All of these patients had a traumatic event, but no fractures were included in this sample. She and co-workers found good to excellent result according to Mayo risk scores in 34 or 37 patients, concluding that early repair of peripheral TFCC tears is a satisfactory method of repair. None of these patients underwent conservative treatment prior to the surgical intervention. We know from other studies that many TFCC tears heal, but the paper raises interesting questions in which patients could benefit from early repair, which is uncertain. Estrella and co-workers published their study in 2007 and found 74% good excellent result in 35 patients at about 3 years follow-up. Patients reported increased capacity, improved grip strength, and pain relief after arthroscopic TFCC repair. In 2008, this German group reported their results in 46 patients at about a year follow-up and found that 63% of the patients reported good excellent according to the modified Mayo risk score, and as previous study, they found improved grip strength and pain relief. The same group did another follow-up at about 4.5 years and found that patients continue to improve in function and comfort at least into the second year after the surgery. However, 5 of the patients needed additional surgery with an ulnar shortening osteotomy to achieve this result. In 2008, the study from Stephen Moran and his group at the Mayo Clinic comparing open to arthroscopic repair of TFCC tears. 75 patients were followed at about 3.5 years, and they found no difference in functional outcomes between the groups. However, the ulnar nerve issues in the open group were more present, and they had reported a high rate of reoperation due to GIUJ instability. Lucchetti and collaborators compared the outcomes after open and arthroscopic repair in 49 patients at about 2.5 years. Both groups improved in all parameters, but they found better DASH scores in the arthroscopically treated patient. So in this systematic review from 2018, the authors conclude there is insufficient evidence to recommend one technique over the other in clinical practice. Further, they point out in their conclusion there's a lack of comparison studies in the area of wrist ligament repair and reconstruction, including TFCC repair and DIJ instability. So even though an extensive effort has revealed new knowledge regarding assessment and management of TFCC tears, there are still questions seeking answers to optimize the outcome for our patients. Many surgical techniques have been introduced, but there is an overall lack of comparative studies. Importance of timing of surgery is not fully known, and which patient would benefit from immediate fixation we don't know so far. Reoperation rate seems to be high and higher, even higher in females in some study, and we don't know why. So an iceberg might look stable, but we should always remain somewhat cautious. There is always more to it. We should search for new knowledge, guiding surgical management to improve patient care. We should look for improvement. We should be curious, but stay out of trouble. So as we summarized in a review paper in the hand clinics, TFCC capsular reattachment could be performed arthroscopically assisted technically, providing good long-term functional outcomes for the patients. So to conclude, arthroscopic suture of Palma 1B TFCC tear showed good results at 20 years follow-up. Thank you very much.
So thank you, Andre, for this trip in a tremendous location, which is TFC. Now we'll jump to the pisotriquetral. Most of people ignore that it belongs to the wrist, but Vicente from Valencia will explain to us what we can do with.
Yeah. Okay. So thank you very much for the invitation to participate. It's always an honor to be here. So I'm going to talk about the arthroscopy and the pisotriquetral joint and the treatment of osteoarthritis. So I have no conflicts of interest to disclose. Well, the pisotriquetral osteoarthritis, as you know, causes pain in the hypotenar eminence, but sometimes can be a referred pain in the ulnar part of the wrist. So we have to have this pathology in mind when we are doing the diagnosis of one ulnar sided wrist pain. Let's take a quick look at the anatomy. The pisiform is a sesamoid bone within the flexor carpus ulnaris, just like the patella in the knee. It's the insertion of point of several ligaments and muscles, forms part of the first row of the carpus, and together with the triquetrum forms the pisotriquetral condylar joint. It's closely related to the neurovascular bundle, since the pisohemate ligament delimits the tunnel of the deep branch of the ulnar nerve, and the pisiform forms the ulnar border of the Guillon's canal. For the physical examination, we must know that the pisotriquetral joint is a really mobile joint. There are several exploratory tests that we must know, like the triquetral grinding test. What we do is to hold the pisiform between the thumb and the index finger and mobilize it medially and laterally. So if we find pain or crepitation in this maneuver, we must suspect pisotriquetral arthropathy. Also, the triquetral shear test, applying. Oops, now it works. Okay, applying pressure towards the dorsal over the triquetrum, stabilizing the triquetrum, and the pain may indicate the joint instability or degenerative pain. It's important to know the difference between this test and the shear test for the lunotriquetral joint, because in this for the lunotriquetral joint we are not going to stabilize the triquetrum, so we are doing the force and the exploration of the lunotriquetral ligament. So the maneuver is a little bit, I don't know what, works slowly. Now, we're exploring in this test the lunotriquetral ligament, and it's different than the pisotriquetral shear test. For diagnosis with imaging tests, we have simple X-rays. Normally, they are not really useful because it can be seen clearly, but there are specific projections like the oblique projection and slight supination and extension is the Garrod view, which improves the vision in case of osteoarthritis. And also we have the carpal tunnel view and ultrasounds that allow us to evaluate the flexor carpus ulnaris. Sometimes we can have some calcifications in the insertion of flexor carpus ulnaris in the pisiform. The MRI for more specific studies on arthropathies, hidden fractures, tumors, and loose bodies. And currently we have also the arthroscopy for the direct vision of the pisotriquetral joint. The pisotriquetral joint can suffer from degenerative pathologies that are the most frequent. We must think about this pathology when we are evaluating ulnar pain. It can also suffer from traumatic pathologies like fractures, dislocations, and other pathologies like loose bodies, tumors, and osteonecrosis. And what about the use of arthroscopy? The subpisotriquetral joint can be seen perfectly through the dorsal radiocarpal portals and through the pisotriquetral direct portal that we will see later. There are 4 types of access to the pisotriquetral joint. Sometimes there is a synovial membrane that make us difficult to see the pisotriquetral joint, but in the majority of cases we have a type 4, and when we have the 55% of patients, we have like a window. Also from the 6R portal we can reach the pisotriquetral joint easily. To facilitate the work on the pisotriquetral space, we can use the direct pisotriquetral portal. We published the anatomical study a few years ago, and this portal allows us to have access to the joint and is safer than the 6U portal. It's located in the ulnar border and slightly distal to the pisiform. This is the portal, and also you can perform not only one portal, you can perform an accessory portal, one more proximal and another one more distal, so you can have two portals to work in this space, and you can maintain the scope in the 6R portal for the vision. We use the standard portal, and then we place the arthroscope in the 6R portal and create the pisotriquetral under the direct vision. We will be used as a working portal normally. But this portal can be used also to view, to have a better view of the radial aspect of the pisotriquetral joint. If the pisiform is not directly visible, we have to debride the synovial tissue. As I told you before, sometimes in 23% of cases we have a synovial there. So we have to clean it like this in this video to have a clear vision of the pisotriquetral joint. We have take care, of course, to avoid the injury of the ulnar nerve that is located in the radial part of the pisiform. In this video, you can see also the direct view from the 6R portal, performing a ballotment test, in this case with a good condition of the cartilage. Several treatments can be performed by arthroscopy, like the debridement for ganglion cysts and synovitis, removal of loose bodies. In osteoarthritis, partial or complete pisoformectomy. We're going to see a video later. And contraindication, previous open surgery in the Guyon canal can make it difficult to visualize pisotriquetral joint and can increase the risk of nerve injury. In cases of osteoarthritis, we can perform a partial or complete excision of the pisiform with greater preservation of the flexor carpus ulnaris and less risk of damaging the ulnar nerve, if we are careful not to damage the capsule and the radial edge of the pisiform. In this video, you can see a case of pisiform excision in a woman with pisotriquetral arthritis. This is the view that we have from the 6R portal, the damage of the cartilage. We're going to establish to do the pisotriquetral direct portal as a working portal. This is introducing the mosquito. We can see the damage of the surface. And then with the saver, we start to remove all the tissue, and we start to remove the bone inside the pisiform. We're going to leave only the covering, the shell of the bone. We start in the ulnar part, and the last part, if the radial part, is where is the ulnar nerve. So we must take care of this in this procedure. We are emptying the bone. So we're going to use now a grasper or beater or whatever to remove the shell of the bone. And while we are closing to the radial part, we must protect this part with a fryer or with a spatula, because we have the ulnar nerve in this part. Here, almost done the pisiformectomy, and you can see now in the next image we can see the ulnar nerve. This is close to the mosquito. You can see the nerve there. And then we finish the removal of the remains of the bone with this spatula, with a bitter punch in this part near the capsule, and really careful protecting the nerve. As you can see, we can remove the remains of the bone in this part and complete the excision. This is the results 1 month after the surgery. And okay, the advantages of this minimally invasive approach are we can preserve the flexor carpus ulnaris and the pisotriquetral ligament complex. We maintain their biomechanical function, and at the same time we reduce the scar pain and post-therapy or post-operative discomfort with better aesthetic results and shorter recovery time. This is the movement only 3 or 4 days after the surgery. This is the previous case. And what about the results of the decision? In general, in open surgery also, with good results have been published with improvement in pain and good range of motion. The pain in the scar area is the most common complication, and this limitation is precisely what we can minimize by arthroscopic resection. Pisiformectomy can be performed safely, and the expected result is restoration of function with pain-free wrist. And to take home, pisotriquetral ICU pain is a common cause of ulnar side wrist pain. The main symptomatic pathology is the osteoarthritis. The pisotriquetral joint can be easily seen and assessed arthroscopically in 75% of the patient through the radiocarpal joint and portals. The arthroscopy is useful to confirm the injury and assess the degree of articular damage. Also for the treatment, we have removed loose bodies and perform a synovectomy, and also a partial and complete pisiformectomy are another possibility to improve the results of the open surgery and in postoperative range of motion and pain. Thank you very much.
Okay, this session is open for questions. Any questions from the audience for any of the three speakers? Yes.
Regarding the arthroscopic pisiform excision, is there any reported number of ulnar nerve complication injury? Always neuropraxia, or there is reported cases of significant injury to the ulnar nerve? And is there any difference between open and the rate of ulnar nerve injury between open and arthroscope regarding ulnar nerve?
I think there are no series about the arthroscopic pisiformectomy. There are only a few cases published. We have now 6 cases, I think. We haven't had any complication about this. It's true that it seems really dangerous, but I don't know, you have the nerve there. You are seeing, watching what you're doing, and if you protect the nerve, of course you can have any damage, but like in open surgery, I don't know. In open surgery you can damage also the nerve, so I don't know why it must be more risky doing it by arthroscopy. So it's true that in open surgery there are some papers with cases of neuropraxia of ulnar nerve, but in our experience, not in our cases.
Yes, thank you.
It's fascinating. I think in open, we have so many problems with the incision, dysesthesia, and I think for those of you that do shoulder arthroscopy, many times now they're decompressing the brachial plexus. So the visualization of the nerve is probably much better with arthroscopy than with an open technique.
Yeah, because
sometimes.
you know where it's in the radial part of the bone. So when you're arriving there, you start to little by little to protect this area, and you are removing only the bone, and you can use a spatula or fryer to protect this part, and I think it's pretty safe.
And do you feel you even need to remove all the bone at that point?
Sometimes you can let there some pieces attached to the ligaments or to the capsule, but it doesn't matter. It's the same.
I have a whole group of ligamentously lax young women who have very unstable pisotriquetral joint. Do you ever operate on those patients? Have you ever seen those patients?
Yeah, we have some cases of instability with pain, and we have done like application with a suture and with a knot, passing the knot, the suture to different parts and closing the ligament, tightening the ligaments.
Arthroscopically?
Arthroscopically.
Does it work?
And the results are really good. Yeah.
Okay. Other questions?
Regarding the experience of the team of Norway, thank you for sharing yours. And I wanted to know, concerning the indication of the peripheral tears of the TFC, do you think we overtreat them, or do you think surgically it makes sense to fix this detachment in all the different patients you see, when you see there is a small detachment, you fix it. Do you think it worth it, or you think you have many of them that we shouldn't touch?
No, I think, I mean, people with persisting pain, ulnar-sided pain, I think there's a good indication for arthroscopy, and if there is a detachment of the capsule, I think reattachment of that is a good treatment option for those patients. But I'm not sure which is the good timing of the surgery. There's no good help in the literature as far as I'm aware of. So I mean, if we see these patients too early, we will probably treat too many. So I think conservative treatment is good in the initial phase. But typically we take these patients to arthroscopy not before it's at least 3 months after the injury. Yeah.
Eric, I have another question for you. You said that it's important to have other studies about open and arthroscopic treatment in these cases, but actually the peripheral tears are mostly diagnosticated by arthroscopy, and when you do the open treatment, you open the capsule, so you actually in some way make a lesion. And when you don't make it, you don't open the capsule, you don't know how much you gain. So I think those tears, not the foveal ones, but those tears have a great bias to compare them to open surgery, because they are very characteristic to arthroscopic surgery.
Yeah, I agree. And diagnostic tools they use for doing an open repair, you must know it be upfront if there's a peripheral tear, and in my mind we don't have those tools yet. So there's uncertainty. But I mean, there's uncertainty with all the studies because the numbers are so low. There's no study with sufficient power to compare anything. But this is what we have. So we have to rely on the data that's available. Yeah.
So yeah, Paul Ramirez on the chat is asking a question about ECU tendon. Asking how can you truly assess the dorsal subluxation of the ulna in ECU pathology, knowing that depending on the position of the wrist during your imaging, for example, the CT scan can depend if you're in pronation, supination. So how can you really assess the dorsal subluxation of the ulna?
In that case, you have a complete rupture of ECU. So the subluxation of the ulnar head is a consequence of that you don't have the power, the tendon in there. So I don't know if you put it, if you treat the rupture of the tendon, you put the head of the ulna becoming in your site. I have a question to André. I don't know if I can do it. You are here in the advanced course of arthroscopy, and that Palmer classification, that the 1B, it's a ulnar side lesion, and I don't see a lot of ulnar side, but I think the ulnar side is more the foveal side. It's a instability. The ulnar side is more dorsal that you show in a picture. I don't know if with the Palmer and the ATSE they don't miss this kind of dorsal side, peripheral dorsal side, and not the ulnar side that a lot of papers call the peripheral. I see a lot more dorsal side than the ulnar side. The ulnar is more unstable, and the dorsal is more peripheral. I don't know if you understand the question.
Yeah, I think I understand. Yeah, I think that's the big thing after size classification was published. It distinguishes between the distal part and the proximal part and the importance of each part. If the peripheral tear is a detachment of the dorsal or a more ulnar-sided, as long as the foveal insertion is intact, I think that's the most important part. But I think certainly a dorsal detachment, either if it's dorsal or more ulnar, it can cause ulnar-sided wrist pain, even though the DIOJs remain stable. I don't know if there's any other thoughts on that.
Yeah, probably we must put other types, or this ulnar side is not so many common that the old papers show us.
So Ricardo, so you mean that to sum up the things, you have only two main pathology for the TFC. You have the dorsal one, and you have the deepest one.
No, I think the Palmer classification, the older classification, they put a lot of ulnar side. That is probably the deeper one, the prevalence. And the new papers show us that the dorsal is only 7-9%. I think it's more. Now that we have the arthroscopy to see, if you clean in that synovitis in the dorsal part, you see the lesion more in the dorsal part, not the ulnar part. I think the 1B is more dorsal than ulnar when you do arthroscopy.
Makes sense. Other question, yeah, Alam?
I have a question. Actually, a question for Ricardo. How much of your ECU cysts are associated with peripheral lesion of the TFC? Do you have only isolated cysts of the ECU, or sometimes you have some tears associated with the cyst? Because I have seen the cysts I have seen frequently are associated with peripheral tears of the TFC.
I think it's all together. You now write a paper with Dr. Andrea Atzey and Corella, doing some kind of technique to make a treatment of this kind of peripheral with tenoscopy and peripheral lesion of the TFCC. I think it's all together. The dorsal part of the TFCC in the deeper part of the 6 compartment sheath.
I totally agree, because in one of your video we have seen an isolated cyst exactly on the sheath of the ECU, but we don't. I think we need to pay attention to the TFC, and we should not miss the peripheral tear of the TFCC. Otherwise, we will have painful patient after surgery. Persistent pain.
I think the cyst can be the consequence of the lesion, and how now you can see the all compartment. You can put some stitch, treat the peripheral, and without the risk of the grab, the extensor tendon or the ulnar nerve, or put the stitch inside the 6 compartment. You can treat with some stitches and put this structure without risk.
I don't know if yes.
I was going to say, how is that what you do if you have an isolated ECU subluxation? Will you fix it arthroscopically, or do you still use the retinacular sling?
I never did that. Fernando Corella showed 2 cases that they make stabilization of ECU, putting 2 bone anchors, one of each side of the ulnar head, arthroscopically. Fernando Corella has this kind of patients in this technique. I never did that.
Do you still, if you have isolated ECU subluxation, do you still open it up and make a retinacular sling?
Yeah. It's an uncommon cause.
It is an uncommon. I agree.
But I will try arthroscopically for sure. but I never did a case. And if I had a case, I will send to Fernando Corella and discuss, and probably I will try to do arthroscopically.
Yeah, I don't know what the other experts think, but I rarely have seen isolated ECU in our professional tennis players. Often they come in complaining. They have the diagnosis of ECU subluxation, but I think it's always associated with a peripheral tear, always, yes.
Yeah.
So,
like we said.
I would like just to have the opinion of the participants about not the ECU, but the pisotriquetral. Do you have any experience, and what do you think about Vicente technique? Maybe in the first row. Do you have any questions? Tadeusz? Yes. Yes, I would like to know, are you, after the lecture of Vicente, are you ready to do it, or what do you think about the nerve?
doing, why not? But so set an indication and find a patient proper. No, it's not an easy. I actually I don't have personal experience of having the patient to whom I would like to do this surgery, but it's convincing.
Because it's a kind of. Can you pass the mic to your colleague?
But Tadeusz, if you have a
That's,
piezotracheal
in my opinion,
prosthesis-
it's really an interesting technique. I think that it's not so common as findings, of course, but if I have a case, maybe I can try. I think that it's for expert surgeon in order to perform this kind of surgery, not for the beginners, I think.
Do you think it is for advanced? Do you have any advice for our participants?
Yeah, I think it's probably for advanced. Yeah, it's true that if you do it, you can do it carefully, but you need some skills and triangulation and. So I think it's for advanced. I don't recommend this technique for beginners.
Because this moment when we see the nerve is a little scary.
Yeah.
What is the main advice that you can give us to do the technique? Because we presented the technique.
Yeah, to start from the ulnar part, you have to remove the bone inside the bone, the cancellous bone, then remove the shell of the bone little by little from the ulnar to the radial part of the pisiform, and then when you are arriving on the first steps, you can do it more quickly. But then when you are arriving on the radial part, you have to be more careful and try to protect this part and remove the bone. Little by little, and be aware that you have the nerve there.
So better to practice in the lab before.
For sure.
Or just Alan, the second option is to book a flight for the patient to Valencia.
Yes, maybe.
Another
Or
option.
to have
I
a weekend
think
to
it's fair.
Valencia.
I would say you only have to do 2 open before you'll start doing arthroscopy, because the patients hate the incision if you do them open. And you do it open twice, you see where the nerve is, and then I think it's a great. I'm going to do it.
Yeah,
I'm not doing them open
because the
anymore.
scar it hurts. It hurts,
yes.
and it's.
But Vicente, I have just a question for the neurolysis of the nerve, because sometimes we have really seldom cases where they have numbness, they're painful, you have nothing on the EMG, and it's a little bit daredevil to try to open it. And have you experienced
I've never done it. I've never done it, but I'm thinking about this.
But okay.
I think it's a possibility that we can explore to because it's true. Sometimes we have a lot of problems with that scar, and we can improve that outcomes.
Yeah, Gustavo Mantovani showed a few cases of arthroscopic ulnar nerve release.
That is a good friend. He has the same mindset.
But I was bouncing off Steve's parallel to the shoulder. I think now there's many shoulder surgeons that release the brachial plexus, and I think actually the exposure of the nerve is very good if you know where to go. Because if in that case you progress from ulnar to radial, as you say, so you know that as soon as you still have bone, it's okay, and then if you know you're moving,
you see the finish of the bone,
but
you
maybe
have to
the
stop.
only difference is in your case you avoid the nerve, and now we target the bone, the nerve, and it's in certain manner it's not an arthroscopy, it's a nervoscopy, a tenoscopy. We don't even know how we enter directly the Guyon canal behind the wrist box.
No, but you
so
have
out of the box.
You have this. You have the bone limit that you know. If you still have bone, you're.
Yeah, but if you need to free the nerve, that's the key.
If you need to free
the nerve. If you need to free the nerve.
Yeah, it's different. Yeah.
It's more tricky. Next session, yeah.
Yeah, next session.
Can I ask one more question for Ander? Oh yes, go ahead.
Yeah, I think is the piezotrachetron and the STT. It's in other direction. In the wrist. So my advice for beginners, or if you want to do treatment in these joints, it's even a normal arthroscopy, radiocarpal arthroscopy. Go to the pisiform side and look at, because it's not easy in the normal wrist. You find the joint, and there are sometimes a membrane that you can find. So it's before they start to treat arthritis, to see a normal wrist, in the STT, in the medial carpal joint, in the pisotrichotron in the radial carpal joint, because it's in the other direction. Sometimes it's not easy to reach the joint. So my advice, it's one step before, try to reach in every arthroscopy the pisotrichotron and the STT.
Yes. In a 20-year study, your average DASH score was still above 20. Do you think that that is acceptable, and do you think your results are better now? It was a long-term study, so.
Yeah, I mean, that's difficult with long-term studies, that obviously things are dynamic over time, and a patient that was 40 in the first follow-up is going to be 60 and have different demands. So I think obviously we should take that into consideration when we look at the results. So, I think the most important finding with the study is that the patient tend to those patients that were good at 2 years follow-up, they persistently had a good result.
And what percentage in your practice now is a peripheral repair like you showed? Do you still do mainly just a peripheral plication, or would you say more of them are through bone tunnels?
More are through bone tunnels.
Yes.
Yeah, a lot more through bone tunnels.
Eric, I have a last question for you. Over the years, there were a lot of types of sutures were introduced. You showed simple sutures, then there were mattress suture, all inside sutures. Before with PDS, now with fiber wires. Did you change your suture type with years, your materials? Can you speak about it?
So all of these patients were treated by Jan, but so they were operated with Pauline, but we use only fiber wire now. Yeah.
And always simple sutures, right?
Yeah.
1 or 2.
Yeah.
Okay.
Okay, let's switch to the second part, more exciting, because we will discuss about clinical cases. Where is Jaime? Jaime is hidden, yeah. So just to introduce him, he's just a little spiritual son of Paco Pinal, and he will talk about acute peroneate dislocation, a clinical case. So the panel should participate, ask questions, and debate, because maybe he's wrong, and
Especially
maybe
here.
No, definitely no, I'm not sure. So
Especially the last rows, we will participate to the case.
yeah. So feel free, we have questions, you have to answer.
First of all, thank you for the invitation and this nice introduction. I have no disclosures, and as Dr. Taleb was saying, my first slide is to show also my gratitude to my boss and mentor. There's Dr. Pinal, he doesn't need introduction, and we have been together many years, and we are still kicking. So just a little piece of information before we jump into the case. So if we have a look to the previous edition of the Greens, and we go to the chapter was written by Margaret Hialias and Alberto Yuc, talking about the close reduction and percutaneous fixation with arthroscopy, they say this. They say that they consider it as acceptable only if the reduction achieved by close manipulation of all the peroneate joints is completely anatomic. And talking about arthroscopy, they say that they consider it like appealing, an alternative in order to get to do this close. Then, sorry for this, then about their personal recommendations, they still strongly recommend double approach, and only if the patient was reluctant to allow open surgery or if medical condition doesn't allow to get to surgery in 1 week, then they would consider to do arthroscopic. Then next edition, they changed the name of the chapter and also the authors, so it's Scott Wolf and Sanjay Kakar. They say the same here in the introduction, but then later you can taste the change in the trend, because they say this in their recommended author thoughts. They say that they both consider open and arthroscopic techniques. They have advantages, and neither has shown a benefit over the other. And talking about the open, they normally try to avoid the palmar approach. So you can see a shift that give us for today. So let's talk about arthroscopy. So this is the case. This is a professional soccer player, completely healthy, and after an official match, after a high jump, he lands on the outstretched dominant hand, the injury went unnoticed. The doctor in the team said, well, there's nothing. And 2 days later, he showed up in the emergency department due to symptoms of acute carpal tunnel syndrome. So these are the x-rays. Dr. Arnault asked me to try to be interactive. So I'm going to spare the first blow here. So this is the classic shape of the lunate with the triangle, isosceles triangle pointing distally because you have a peroneal dislocation. But there's something that the radiologists call satisfaction of search, meaning that if you find something that is huge or a big finding in the x-ray, you may be satisfied and not look for something else. Is there something else here? Can anybody here in the first row tell me there's something else? Yeah, something like that. Is the microphone around?
There is someone here. Is there a participant here? Can you tell us where you're from? And
I'm from Mexico. No, I think I didn't see anything else.
I'm gonna give you a hint, okay? What about this? I'm gonna give you 2 extra hints. Another X-rays we use. You can see the obvious. And what is this?
Jaime, can you help
So-
us a little before? Can you come back to the X-ray?
Oh, sure.
And help us a little. Give us some.
Always, I would say for the young doctors, always think about the greater arc, potential for a greater arc injury. So something in that triquetrum doesn't look right. Also, the overlap between the hamate and the capitate is a little unusual. Maybe just that the carpus is rotated a little bit. But we worry that there may be a fracture through the triquetrum.
So, Jose Enrique, what is your conclusion here? What do you do?
And it's acute, so we'll try the close reduction, I think. So.
But before getting to that, I suggest you hear the experts because he may be very right. So,
sorry, Jaime, we have another. No.
So all this little joke is just to move your attention to what is the next step. So it's not getting to the OR and try to do things. It's trying to understand this. So that's why for most of these cases you need to ask for a CT because that may help a lot. So that's the learning from this. So there you go. You have the CT. So those are coronal cuts. You can see here that there's some dorsal avulsion coming from the lunate. Here the lunate, the gilula line is missing because the lunate is missing. As Dr. Moran said, that ghost that was around in the wrist belongs to the triquetrum. So there's a fracture too. Here in the sagittal cuts, we see the scaphoiding in its place, the lunate is dislocated, and there's a piece of bone that went off. And finally, here in the axial cuts, again, the dorsal avulsion and the piece of the triquetrum that has followed the lunate forward. On the second row, that is okay. So pretty much we have this situation here, and part of the triquetrum is still attached dorsally to the lunate that has gone volarly. So it takes us to think of then how do I reduce this? All right. So if the situation is this one, the way to go is like this. So the lunate has a trip companion. So if we reduce the lunate, then we reduce the triquetrum. All right. So as you know, there are many ligaments here, but talking about related dislocations, what we are going to focus on is the dorsal part of the scapholunate ligament and the volar of the lunotriquetral ligaments that are the most strong ones. So the mechanism to have an injury like this could be represented like so. I won't stretch again into the details on how we do this, but I strongly recommend to use dry arthroscopy. The system that we use that is all fully explained in those books, so I'm not going to get into the details again. So now, after fighting with the administrator to get a CT on a Sunday, we are in the OR. Remember, this patient has been 2 days with the dislocation on, so first thing we do is to apply traction at least 10 minutes straight traction and see if it goes into reduction or not. So this is the picture after 10 minutes. So we pretty much are still the same. So the lunate is not in its place. Now we know the piece of the triquetrum has gone.
Just one question for the panel before going further. Do you have any chance to get an emergency CT scan for a non-reduced dislocation? I mean, you have time?
Maybe
Or
you can ask what they would do in their hospital.
In your
Maybe-
daily practice, you
Yes.
have this, the X-ray, the plan X-ray. Do you jump on the patient directly in the upper room? You have time to make a CT scan? Do you think it will help you more? Or what is your daily practice? Let's ask a military
Maybe
surgeon.
Romain from France.
He's
he
a
can
military
have,
surgeon, so
his
maybe he has
his point of view.
Yeah.
What do you do in this kind of situation in Besançon?
Toulon.
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 Yes.
I'm not sure to plan if a CT scan before to go. For me, the first time is to reduce, and if there is no median nerve suffering, I can try to with traction to reduce it without opening procedure, and if it's impossible, I open.
So in your daily practice, you reduce without CT scan. You try to reduce without CT scan. Can we have maybe another point of view from the maybe in your hospital? Yes. Can you please your mic? Can you tell us from where you are and what you
in
do?
emergency setting, I always try close contact.
Sorry, just where you from? Just to compare the habits. Where you from? Your hospital, your city?
I'm from Iraq, from
Okay.
Basra. Yeah. I always in emergency setting I will try close reduction. Then I plan for elective fixation after making full investigations like CT scan. But first I'll try just to relieve pressure on the median nerve. I'll try to reduce it. But unfortunately, most of the time we face this condition delayed. So it is impossible to do a close reduction.
So how do you reduce them? With anesthesiologist or just longitudinal traction, or do you do some maneuvers?
Under deep sedation, yes, traction on the fingers for about 5 minutes, finger traps, and then try to reduce it.
Sorry,
just thumping with extension, yes.
I don't understand. You don't ask a CT scan because you don't have a CT scan available. It's not in your habits, or why do you go directly to the reduction? That is just a question to know.
Yes, it is. It is not always available at night or at any time, and it is time consuming, and we have to relieve the pressure on the median nerve.
So it's interesting because the habits. Sarah, maybe in the UK, you can tell us what you do in this kind of situation. Sorry, can you the mic, please? Can you tell us where are you from? And in your hospital, if you have the same case as Jaime is showing us, what do you do?
Sorry, as a reminder, the patient has been 2 days with the carpal tunnel. That's an important detail. So go ahead, please.
I'm from London. We'd get a CT in A&E straight away. We'd get a CT before reducing.
I don't see you.
We'd get a CT before reducing in A&E.
In the UK, okay.
Before we go on, can any of the young doctors tell me what is holding that green fragment there? What pulled that green fragment off the lunate? That's the short radiolunate ligament, right, that you looked at today? So just, I think a strong argument for doing this arthroscopically is that the majority of the volar blood supply enters the lunate through that short radiolunate ligament. So if you open this up dorsally and volarly to get it reduced, there's a good chance that lunate may disappear and go away on you in a couple years after surgery. So just recognize that the deforming force is the intact pisotriquetral ligament that's displaced that fragment from the triquetrum, and the short radiolunate ligament, which you all saw when you did your radiocarpal arthroscopy, pulled that piece off the lunate itself, so of fracture avulsion injuries.
May I just add for the therapy, the primary therapy with the reduction. The reduction is not complicated in those things. Enough time, enough traction force, and then you press and decapitate and it pops back in. It's not even so painful for the patient, but people have to know it. In our emergency department, there's not always a hand surgeon present, but this kind of reduction has to be done by any doctor. So this is not, you will have a problem to find a specialist maybe 24 hours a day to do this surgery. Not everyone can do the surgery, but everyone should be able to recognize the problem and treat it. And the treatment first is with reduction. Exactly. And in those cases, in my hospital where I've been trained in Innsbruck, if we would have done a CT scan before reducing it, we would be short ahead. Yeah, so it's like, the first and primary treatment for us is the reduction. Then we have time, then we have planning, then we can analyze and be academic about it. But this is a straightforward treatment for a common problem.
But the acute CTS is an issue for you here or not? Because for Jaime, it is one of the crucial points of,
It is for me too, and the treatment for acute CTS is increasing of the space, reduction. The CT scan won't treat the CTS. A surgery might do so, or the reduction does. But it's not a case for CT scan here or there. This is, sometimes I call it a first world problem. It is like, what is the problem? There's not enough space for my nerve. I have to decompress, and the first decompression is reduction.
Actually, I agree, because oftentimes when you have a perilunate dislocation, after reduction, the carpal tunnel symptoms will eventually resolve. And personally, I like to do, I think it's important to do CT scan after reduction because you get a lot of information from it. When you do a CT scan before reduction, like the bones are just pretty much everywhere. You don't really get much information, I personally think. And also sometimes you do get sort of a perilunate injury type of fractures. Like on a regular x-ray, you may not see a fracture, but then when you do a CT scan after reduction, you can see some missed capitate fractures and so on. I personally think that CT scan after reduction is more useful.
Can we ask how many people would do the reduction or the CT scan here? Panel and all the participants, and who is for the reduction directly? Okay. Can you count, please?
But Alam, we just have.
You're missing.
Alam, just keep in mind that it's a delayed one.
You're missing that point.
Yes,
so this is 2 days after.
I know, Jaime.
So,
it's a question.
Yeah.
So 2 days and CTS. 2 days and CTS. Who is doing reduction?
2 days is nothing. And this picture shows everything I need to know.
Look
there
at this.
There is a lot of ligament rupture, so I have enough space to reduce it even after 2 days.
So this picture is in the OR after
Yes.
10 minutes traction and it's still unreduced. So it's not that easy reductible 2 days after. As is in acute setting. That's why I'm showing you this.
But Jaime, my
2
question
days
is, when you see the
acute.
patient, before getting the patient in the OR, how many of us are doing reduction and how many of us are asking for the CT scan? Is interesting to know.
And I think 2 days is no time for scar formation. So if I have a scar, I've done one of those cases 6 weeks old, there you get your problem. And with arthroscopy, I can debride and get the scar loose, and then I can do the reduction. But 2 days, I would not mind, because I don't lose anything, because it takes time until you are in the hospital and the guys at the emergency department have to react somehow. So I would definitely give it a shot.
And Alberto wants to give his opinion, please.
In how many cases we perform a CT scan before to try to reduce a shoulder dislocation? In any one case.
All of them.
We try to reduce the shoulder, and if we are unable to reduce the shoulder, we try to understand why. And my approach is, okay, it's past 2 days, but why don't try to reduce? If we try to reduce, and if the dislocation is not reducible, in that case, we thinking about a CT scan and all that you wanna. If we reduce the shoulder, we try to reduce the shoulder, but the shoulder not maintain the reduction. At the end, they say, okay, probably there's a fracture of the glenoid or the other thing, and it's not relevant, and we try to investigate for understand it. But the dislocation in orthopedic surgery is an emergency. When we are during the night and arrive the patient with a dislocation, we are calling from our bed and we go into the hospital to reduce. This is the sense of it. Okay, if you say, I try to reduce, it's not possible to reduce it, okay, I perform a CT scan for understand it. I'm agree with you. But to perform a CT scan before to try to reduce, in my opinion, is not correct.
Even after 2 days.
So we have a complete different approach in this. So our idea is if we are going to do some kind of anesthetics to try to reduce this for this patient, then let's do the full treatment just in one blow in the emergency department. So we take the patient to the OR, do the reduction and keep going and do the rest of the work with the arthroscopy. And for that, it's better if you have some intel before. So that's our different approach in this.
Sorry, Jaime, can we ask maybe Pedro what you would do? Yes, Pedro Delgado. Maybe. And after I let you with your case.
Yeah, sure.
Because it's interesting.
This is fun.
Point.
I completely agree with Alberto because, in fact, the CT scan findings probably don't so important to the treatment. You're not going to change your objectives or the aim of treatment using the CT scan. It's true that you had 2 days after the trauma. Why not to wait some hours to prepare CT scan to have more information to plan the surgery? But probably the most important now is to try to understand the fracture and, so, of course, to try to reduce as soon as possible the reduction. Probably the CT scan is fine, it's literature. It is to have a good planning, but probably it's not important in this case. The most important to try to reduce, and probably the most important is the maneuver or the reaction or anyway, but not in CT scan. But of course, if you have time to understand this, why not to have a CT scan? But not always is possible, especially in the public system.
Yeah, that's also true. I mean, if you can have it quickly, then why not? If you have to wait a week to have it, then obviously you have to reduce it first.
We all agree.
Consensus. There is a consensus.
Pretty much.
Let's jump to the next step. Yes. So.
All right, so next steps. So this is the view after extraction. So that's the scaphoid and the capitate. And then we are going to move forward and see the anterior and posterior scaphoid ligament that are completely torn. And if we keep going anteriorly, we'll find the lunate. And if you turn a bit, in a sec, you will see the facet for the capitate there. And also the anterior capsule where it has an injury in the space of warrior. And since the lunate is gone anteriorly, we can go around it and get to the other side of the breast and see the LT ligaments that are also broken here. So now you know perfectly what is going on here, and it didn't reduce by itself. So we have to help. And the way to help is this way. So we will use a mosquito and push the scaphoid gently, the lunate. But while doing so, we have to take extreme cautious with the scope, because one, it reduces, it closes suddenly, and we don't want to catch the scope in this maneuver. So that's why we're pulling back the scope, because we don't want to break it. So this is the fluoro, and with this traction device, you see the fragment there, and we are gonna release the traction. And now we get the reduction that we want. So the jugular line is there, the fracture is reduced. So we go back in with the arthroscopy and see what happens. So there's the lunate that is bouncing back and forward because it's completely disconnected. There's an anterior avulsion there in the capsule. You can see there is a big step off in between the scaphoid and the lunate. And in the other side, same goes for the LT joint, and there you can see the torn anterior LT ligament. So maybe here we can have another discussion about, okay, you have seen straight the ligament that is torn. Who would like to put a stitch on this?
The treatment you are looking.
Yeah.
We need to ask the participants, not the faculty.
No, I'm asking.
So Jeff, you have two surgeons, experienced surgeons.
We have Paris here. Paris, can you please give us your name and tell us what you do here in Clinique Monceau?
Yes.
Clinique Monceau.
Samuel from Paris. In my practice, I make open reduction and fixation. So I don't know. I think I make K-wire fixation and that's all.
Because you think you don't have the skills to do the arthroscopy, but now you did the advanced course. If you put your scope inside and you see this, what would you do now? Samuel? No? Always the same? Okay. The same.
I do the same with, my name is Axel Kelly from Besançon. I do the same with K-wire and capsulodesis for scapholunate, and that's all.
Capsulodesis?
Yeah.
In the panel, just a question: who will only put key wires and wait it heal by itself? Great, great. So don't be shy if you don't want to put a scope. It's just challenging.
Shiab, you are influencing people. You are
No
saying
way.
great.
It's a poll. No, it's just a question. I mean, there are some teams that only put key wires reduction and say it's an acute injury, so it will heal by itself. Others would say we will stitch it because it's acute, but it needs to be stuck each other. So I wanted just to have your minds, because some of people, it's beyond arthroscopy. Would you think that it can heal by itself, or it's just a question of stitches or anchors? Because most of the times we try to stitch a scapholunate ligament, and we for sure know that it never heals.
Excuse me, I have a question for you. What is the major problem of the dislocation in a long time? Is instability or stiffness?
Necrosis. If you're open.
Also necrosis, anyway. And you can resolve the necrosis with ligament reconstruction?
For sure,
stiffness. This is the point, the critical point for me. If any in the dislocation, all that we do is a stiffness movement, you know, is a stiffness passage. Okay, even we reconstruct something, we create the base for more stiffness of the soft tissue. Okay, the necrosis is a great problem, but you cannot resolve the necrosis if you create a hole for a screw inside the bone. Okay, we are agree on it, and the major of the problem is the stiffness. And I think with arthroscopy we have a better idea of the realignment on the bone. This is a very relevant topic. We can assist our K-wire by arthroscopy for be sure of the correct position of the bone. I totally agree with it. But in my experience, to try to reconstruct the ligament, we create a base for more stiffness, and this is not our aim. This is my.
Carla, what is your experience?
My experience is I do a volar portal for the lunotriquetral ligament, and I do a Magellan type capsuloligamental suture, and it increases, there's partial stability in that. So after that, the entire carpus looks a little bit more tidy, and you can manage it more easily. You can even fix your scapholunate more easily after you've done that. And that allows to have the K-wires in for a shorter period of time, so it does not increase stiffness.
Okay. Yeah, and I agree with her, and also about arthroscopy, not only for the reduction, you can also clean the hematoma, remove the small loose bodies that you have, osteochondral injuries. So I think you're going to improve the results of the stiffness with both advantages, what Carla says and the other part.
Let's keep going. So as Chiab said, our policy is try to reduce as good as you can, and then let things heal by itself. So we look for the radial styloid, a little bit distal, and do an incision to protect the nerve and the vein, and always use a soft tissue protector. We do this on top of the table, so we release the traction. So the trick to hit the spot with the scapholunate key wires is to aim to the ulnar styloid. So we'll go ahead and put a couple of those. Preset the key wires here in the scaphoid, and same goes for the LT joint. We will palpate the trichetum and aim to 3-4 portal in order to get these preset key wires here. Remember, our bone is still there. So one important remark while reducing this during the arthroscopy is that you may unreduce yourself with the scope on top of the lunate that, remember, that is completely loose and balanced now. So the way to do it is to try to put the scope not on top of the lunate but in the capsule to avoid this effect that, as I mentioned, while reducing distal radius fracture, it's a little bit like this. You don't want to trip with yourself with the scope. So you need to put the scope somewhere far from what you are reducing. And another advantage of the arthroscopy is that you know exactly where the key wires are before going forward into the lunate. You know where they're going to exit, if they're going to be in the correct spot. And there's another thing that you need to know. To do this, we normally use a freer or some thin and flat instrument, and we will reduce the traction after being inside the joint at least in half, in order to make things easier to reduce the dislocation. So this is how it looked like. We're gonna go there and put a freer to correct the position of the lunate, and the other surgeon, while putting the key wires from the scaphoid to the lunate, he will also press with the soft tissue protector, trying to close even more the gap. So you will see the bubbles coming in, meaning that the key wires are passing by. And then we're gonna check if this is stable or not. And same goes for the lunotriquetral key wires that we are gonna finish introducing to the other side. So the idea is to be able to close to reduce this as close as possible, to make the torn ligaments to be in contact and then being able to heal by itself. And this is the fluoro in the OR with the key wires and the fracture. And this is the immediate post-op with the fracture there. And this is 1 week after. One of the advantages of using dry arthroscopy is you don't have any swelling, and that helps a lot, especially while trying to aim these key wires, because you can palpate easily the bony landmarks. We normally left the key wires out, so that means that we have to weekly take care of this and remove any crust to avoid infection. And we tend to keep them immobilized for 8 weeks. So this is 4 weeks. The fracture is starting to heal, and this is 2 months after. We remove the key wires, and you can see here that the children line is okay, the fracture is okay, scapholunate angle is normal, and this is 3 weeks moving. Sorry, I'm gonna move forward, and this is my take-home message. I use a CT if you can, and it doesn't delay your normal treatment. With dry arthroscopy, apply 10 minutes of traction, and if it doesn't reduce by itself, you have to help, taking care with the scope. Aim to the ulnar styloid and 3/4 portal for the key wires, then release half traction, and do not place the scope on top of the lunate, not to trip with yourself. Immobilize for 8 weeks, and start with dart throwing exercises that mainly occur in mid-carpal at the beginning of the rehab. And with this, 4 months, you can get this kind of results. So thank you very much. And enough. Alain.
Thank you. Jaime. Thank you. Very good. Jaime, I am really surprised with the outcome, because you allow your patients to perform push-ups after this kind of injury. It is forbidden for me for 1 year.
He didn't allow nothing.
There are some questions for the participants here for the case. Would you do? Okay, we move to other case.
All right, thank you.
Okay, for the last case, Oscar.
Yeah, thank you.
Just before, we have a question from the chat, told me Dr. Melanie.
Yeah, sorry, just last minute question for the previous technique. Someone is asking if you would eventually use a tightrope instead of the K-wires. You know, there's a smiley face technique described where you use a tightrope for the whole proximal row. One being fixed on the radial side of the scaphoid and the other one being faced on the ulnar side of the triquetrum.
Smiley technique of
smiley technique.
Yes, of our friend from Turkey.
Would you use that for
Bullet.
instead of K-wires on both sides to repair that, impregnate?
Jaime, the smiley technique.
I like to smile a lot. I come from a school where we trust key wires to keep reduction while ligaments are healing, like in a stenotic lesion or things like that. So we are very happy by using key wires that then we remove, and there's nothing else but the healing of the proper ligaments. So we don't do that.
Can I just add that here we are in an acute case, and I think it is very important to highlight the point that you are restoring the anatomy. So that's probably why we have a good outcome, because we restore the anatomy, we put the key wire, we stabilize. It's not the same case as in the chronic case. It's a traumatic case. And maybe here, what about the extrinsic ligaments, Jaime? What is the status of the extrinsic ligaments here for you?
So, the point is there are lots of things that are broken, and if we are able to put the bones where they should, everything will heal. It's a little bit like in the distal radius fracture that we tend not to overdo things in TFCC tears associated with fractures, because once you restore the radial anatomy, pretty much everything will heal. So that's our thoughts in all this.
Thank you.
Okay. So final case. This is a case of a colleague of mine, and I'd like to say first, you're all aware that the ulnar-sided wrist pain can be many things in a small area. So this is an example for this this topic. So we have a 55-year-old woman. She's previously healthy. She does have a little of she has a little nerve stimulator in her leg from a previous injury, but otherwise she's quite healthy. She's referred from another hospital, and she had a distal radius fracture 6 months prior, where she had a fall, and she still has ulnar-sided wrist pain. So on exam, she has a good range of motion, almost symmetrical. She has pain in the fovea, and she has an unstable DRUJ. Slight pain over LT on palpation, and some pain over SL, but a negative Watson shift test. So, question to the participants: how would you handle this case?
What is exactly the question? What we should do?
Yeah, just.
Yeah.
I can speed it up, but
our friend. Can you please tell us where you're from and what you would do in this case?
Yeah. Hi everyone, I'm David Chi. I'm a fellow at Mayo. Pain in the fovea suggests potential TFCC pathology. There's pain over the LT, so potential LT injury. Since those are soft tissue, I would get an MRI.
Yeah, that's a great idea, MRI would be could certainly be helpful. We just also have to be aware that for the TFCC, for instance, it's not perfect. It can be also negative, although she has maybe a TFCC injury. So in this case, she had that nerve stimulator, so that they didn't want to do an MRI. So he took a CT scan for a plan B, sort of. And the CT scan was quite normal, normal bony anatomy after the distal radius fracture, but no MRI. So I'll just go on. She was referred for diagnostic arthroscopy. And in the radiocarpal joint, they find the old fracture, but no step off. A small chondral lesion on the scaphoid, but nothing much to worry about. DCSS intact, proximal SL intact, but there was a proximal LT tear, and you can introduce the hook into LT. The TFCC disc is intact, poor trampoline effect, semi-positive hook sign, positive ghost sign. So some positive findings. Mid-carpally, no bony or chondral injuries. A lunate type 2 and an SL, very partial injury, but dorsal ligament intact, LT, EVAS grade 2 to 3.
Just because going further, just one question for the panel. When you scope on the mid-carpal, do you oftenly notice that the hook can go between in the lunotriquetral space or not, compared to the scapholunate joint? Do you think you can easily or oftenly go through this joint?
As usually, we need to know what is normal, to know what is subnormal and what is not normal. And for the lunotriquetral, I think it's quite difficult to analyze what is not normal.
So what is your feeling when you scope? Because you assess a lot of things when you have a scope. And as he showed us in this case, we don't have an injected pre-op examination. So we have to refer on what we see while the arthroscopy of the wrist. So do you think that when you push the hook between the lunate and the triquetrum makes that laxity exists, or is just something that can be normal laxity and you don't need to address it? What is your feeling? So if someone dares to give us his opinion,
I can give mine. I guess in a lot of cases you assess everything as you go in there in the mid-carpal. In a lot of cases, I feel there's a laxity in the LT space that is asymptomatic. I mean, that's not the problem for which the patient is in the OR, but you feel there's a laxity. I usually don't do anything because that's not the problem. But yeah, more than the scapholunate.
Yeah, it was my own feeling. I don't know if the experts share with this one, but you have really to be careful. If there is no pain before, no symptoms before, it's just laxity, and don't overtreat laxity. Just like in the shoulder, don't overtreat the laxities, because it leads you to a lot of problems and not happy problems. So you have a feeling regarding this, Steve?
Yes, I would say that symptomatic laxity is always associated with synovitis. So if there's no synovitis and you have a lax joint, I don't consider it pathological at all. So I think that the other thing that you'll see many times in a symptomatic LT is a avulsion from the capsule off the back of the bone. You'll see the cortex, or sometimes even the cancellous portion of the bone, through the ulnar midcarpal portal. That's always a pathological sign. And so that needs to be fixed. So I think that's a telltale sign, and the synovitis, that you have a symptomatic LT instability.
Okay, so I'll move on. The DRUJ arthroscopy findings also. There is some synovitis around the fovea and not normal foveal fibers. So this is a thorough arthroscopy at all levels, including the DRUJ. So the conclusion, I'll just jump a little bit ahead. What's done? It's done at TFCC foveal refixation. And as far as the LT, you might wonder, it was discussed to do thermal shrinkage of the LT ligaments, but due to that nerve stimulator, this was not done. So she was put in a cast and went to rehab. And 6 months after surgery, she has a stable DRUJ and good range of motion, but she still has ulnar-sided wrist pain and positive LT tests. And still no MRI due to the nerve stimulator. She also lives in an area of the country where it's not so easy to get these things without traveling. So
maybe you can ask a question for the participant. What means for you positive LT tests? You have ones in your had in your toolbox that you oftenly can try to make in order to...
we have a participant here just on my right side. Can you please, the mic, you tell us your name, please?
Yes.
Did you do the advanced, the basic, and where are you from, please?
My name is Mahmoud from Turkey. I'm here for the basic course. I have no experience, any arthroscopic experience, but I will say that there is a lunotriquetral ligament disruption. Maybe debridement should be done for the treatment, but I see that you make a reconstruction.
I was a bit.
You're at the basic course, but you are really smart, so it's okay.
I see that, but I think maybe debridement should be done.
But even though you're not trained in arthroscopy, in your outpatient consultation, how do you assess that something happening around the LT joint instead of TFC, as maybe you can be mistaken at the first step of this story?
Before come here, after maybe I will lengthen the conservative treatments, maybe some injections, maybe. But
So
this course will be change my treatment modalities.
You have a comment, Steve? Maybe?
I just think that to identify two good tests to identify lunotriquetral pain is to grab the pisiform and the triquetrum with one hand, and then put your thumb on the lunate and shuck the joint. And if they have an LT tear, they will scream. That is very uncomfortable. That's a very reliable test. The other test is to put your thumb above the fovea and push on the dorsal ridge of the triquetrum. With your other finger, push the scaphoid towards yourself and push down on the lunate. I don't think that's as reliable, but that will also produce pain. But if they have a TFCC tear, that can be misleading. But I think the shuck test is very reliable for patients with a symptomatic LT tear.
Sorry, Stephen, sorry, Asgeir. I think one of the questions now is, have we done a mistake in the first place? And David, what do you think? Do you think they did in the first arthroscopy? Can you go back, please? Can you go back to the first?
Yeah, the question, were we mistaken at first step, not treating?
I think that's a good question, but maybe we can move ahead and then we can discuss later, because there's more. Okay. She was planned for a new arthroscopy and possibly a LT reconstruction. And this time I have some imaging. This is the LT probing midcarpally. So in the left wrist, so there's an increased gap, but it's not completely wide open. If you look at it from proximal, you can always almost enter with the scope, but you see there's some remnants of some tissue there. So there is something back holding it. But she has pain. Yeah, so the TFCC was now deemed stable, also with arthroscopy, and they decided to do an LT reconstruction. Of course, there are many other things you could have considered in the literature, and we'll do this short in the manner of time. But arthrodesis hasn't been so favorable as far as results, but many treatments for LT has been described otherwise, like pinning, debridement, tenodesis dorsally. But our unit has put together an arthroscopic method, which was published by my colleagues some years earlier, and I'll just go through this shortly. But it's two small incisions, and you drill a canal through the triquetrum. The lunate first, and then through the triquetrum, and these two tunnels converge volarly. So you get that kind of angling, and this is a technical part of the operation to get things around that 90-degree angle. But when you've done that, you can then transfer the tendon through those drill holes with the tendon shuttle. We suture the fiber wire to the tendon shuttle and pull that ECU graft 2.5 to 3 millimeters through that LT space. And the LT has, its strongest volarly, so this makes sense as a reconstruction to reinforce the volar side. And then pull it up, and you can see that tightening. And you put PEEK screws first in the triquetrum and then in the lunate. And then this is not that particular patient, but this is from another patient. And you pull that back on itself to recreate also the dorsal ligament, suture it to the ECU, back to the ECU itself. And finally, you go back on the radius with a small incision to complete the secondary stabilizers, which is the dorsal radiocarpal ligament, all with the same tendon back and forth. So this is a neater way, perhaps, to do it than the open. Basically, same technique, at least smaller incisions and less soft tissue damage. So our patient, back to the patient, she comes back. She's been back many times, but she's 2 years and 3 months after this reconstruction. She does feel better, but she actually still has some ulnar-sided wrist pain. So they seem just don't want to go away. And it's mostly reported now pisiform fovea and over the DRUJ, which is fixed and stable, full rotation. But her ulnar carpal stress test is now positive. Any suggestions?
Really tough. Any participant who
wants
does,
to answer
to bet on a diagnosis? So you mean it's the third time that she comes back because she's painful? My first question is hasn't she a crush on you? Maybe she wanted to see you. That's the question for me. No, you know, because honestly, for me, I don't know what to do. I don't like injection, but I would propose an injection.
We have Anna Claudia. Anna Claudia, she wants to give her opinion. Please, Anna Claudia.
Don't be afraid. It's okay.
Tell us what you would do here.
Yeah, I don't know. Maybe ulno-lunar impaction conflict. It's the.
Yeah.
How do you go forward in the diagnosis? What do you do in practically?
The tests in the deviation, radial deviation, and to see if there is effective pain and conflict. After an ERM to see also if there is an edema at the lunatum and ulnar site.
Yes, I think because she's ulnar neutral, this would be a dynamic impaction. And many times after fusion, and maybe after LT reconstruction, I think patients are more susceptible to dynamic compression. So I think, remember, if you fully pronate the hand, the radius will move proximal by rotation. And then if you have the patient go into ulnar deviation and compress, they'll be very painful. So I would suspect some type of abutment compression there. And I know she can't get an MRI, but I would shorten her.
That was in line with our thinking. This is a new arthroscopy, and on the first arthroscopy I didn't have images of, but it was said that the disc was intact, and now there's a hole in the disc. Okay. So, and this was the LT probing. View from the MCR portal. Seems more stable than before. Yeah, so she has a perforation in the disc. The LT grade has gone down, but there's a little bit of she's not super tight, but clearly tighter than before. And she also had some PC-form pain, and this was removed actually in an open incision, and they did an ulnar shortening. So it looked like that. And 4 months out, after this last surgery, reports definite improvement, almost completely pain-free in the wrist. And she has a little bit of reduced mobility, but it's increasing. And her grip strength is also on its way up. And we don't have any more follow-up yet, but yeah. So this is an example of how difficult LT and ulnar-sided wrist pain can be.
I have just one question. You are inside the joint. Why not a wafer procedure, since it's only 3 millimeters of shortening made with your plate? Was it for purpose, or you're not used to doing this arthroscopically? You don't like this procedure? What is your feeling concerning this choice?
I think, to be honest, this is a matter of preference for the surgeons. Some like shortenings better than wafers, but I think that wafer would be a good option here also. But you might be missing one thing with the wafer, and in this sense, you can get an additive effect of tightening the LT through the ulnar shortening through the ulnar carpal ligaments. So if you're still worried about the LT, that might be a benefit.
Could you go back to the last X-ray that you have?
The erosion.
I feel, I don't know, I might be wrong. I feel that there's the LT joint is actually very ulnar, and the lunate coverage by the register is actually very small. So kind of like there was some kind of ulnar translocation of the carpus, which is not really the purpose here. But in some kind of, with that kind of X-ray, sometimes you can have impingement between the styloid of the ulna and the triquetrum. Have you considered that might be also maybe? Clearly here it was not the case because you cured them with the shortening osteotomy, but maybe you treated that with the shortening osteotomy also.
Yeah, I think that's always a thing you can consider, the PC-form thing, and the Ruby test. But in this case, I don't think she has ulnar translocation. I think it's very dependent on your radial.
Yeah, I don't think ulnar translocation is the problem here, but I find that compared to a normal X-ray, the space between the styloid and the triquetrum is actually quite small. So might be also something that you might have to think also in that kind of ulnar pain.
But in these cases, you have in these cases you have in the MRI you have some mirror signs, edema, and.
Yeah, we can do the MRI here. So
we cannot do the MRI. Sorry,
I think that's also a good case to show that an MRI could be helpful here, because it could maybe rule out some things earlier, or show some things like edema. Sometimes you can see in the lunate if they have impaction, but not necessarily always if they have dynamic impaction. Maybe so. There are several things to consider.
Ian, you wanted to add another comments concerning this?
I think this is a good case, and probably we did something wrong. We could turn it upside down and ask if this were an ulnar impaction from the beginning, that secondary had given an LT instability. So the question is, if we had shortened the ulna in the beginning, could we have skipped the LT?
Yeah.
Then we probably wouldn't have addressed the LT. So this we have to think about.
Yeah, I think by shortening the ulna initially, it's always easy to say in retrospect, but you would have tightened the oblique ligament, stabilized the TFCC, and tightened up the LT. But it would have been, she didn't have any other findings of impaction initially, so it would have been very hard to make that diagnosis.
And we would have done it if it would be an ulnar plus, because we would not refix the
Yes.
TFCC with an ulnar plus. We would also reduce the height, so it would not have come to the problem.
So we just invented a new technique of the LD treatment. It's the ulnar shortening, right?
It is.
But it is used for
It
LT.
is a technique that is
Yeah.
that is already described. But
Yeah.
I think there is only one or two series that are published. I don't really remember.
At least Tashi Nakamura has one.
A lot of this.
No, with shortening and LT pinning, actually. Yeah.
Yeah.
But,
I don't understand. I have a question. Asgeir, please. In the first arthroscopy, I go back to my first question.
Yeah.
You found an acute LT instability. And how did you make the decision to do nothing?
To do
nothing, yes. To do abstention, therapeutic abstention for the first arthroscopy.
Yeah, why nothing was done with the LT
anything on the LT
in the first place? Yeah.
It's a question only.
Yeah, that was like I mentioned, because you had the option of doing the shrinkage, but that wasn't on the table due to the nerve stimulator. But I think the idea was still that the TFCC was her initial problem. So this was looked at more like a incidental finding. Perhaps it had some relevance, but perhaps not.
So that means in the acute cases, when you find lunotriquetral instability, because you know that the clinical examination is not that specific preoperatively.
It isn't, and especially when you have a TFCC injury.
Yes.
I think lots of these, especially the first for proximal row compression test, it's always positive almost when you have a TFCC.
Yes. Because the area of the clinical examination is very, very, very small here.
Yes.
So nothing is really specific. So don't you think we should, in the ulnar-sided pain like this, treat everything? Or do you think it's an unnecessary indication?
No, I think that's probably a good point, as long as that's where the pain is in the wrist, of course. But like it was mentioned here before, if you just scope a wrist for any other reason and find a lax LT, I don't think you should do something. But when the symptoms and the arthroscopy findings align, yeah.
But I think for this case, for one thing, I don't think this is an acute injury. It was not. And the other thing is, when they found the foveal detachment, that was something that could explain the pain. And there was just probably one surgeon available. And for the LT reconstruction, it probably take 4 hands.
Okay.
So I think that's an issue to take into consideration as well.
But Jan, the isolated LT, in my opinion, are very rare. So there are maybe always associated with other mistaken lesions. So don't you think it's not just a question because you specialize in the LT? Don't you think in this kind of cases, because we are not sure that the LT instability we have found in the first place cannot be attributable to the pain. So the pain is related to this LT instability. Should we do something simple like the debridement and pinning or capsulodesis?
No, I don't think so. But this could explain the pain for the foveal detachment. That could give pain as well. And so even though the LT is isolated, injuries are rare. This could be a rare case. You never know. There are some cases, I know Lorenzo has done some cases in France, and there are other people who have done some of these cases, so they do exist. But again, I think this the first finding could explain her pain, and I think that's why the surgeon performed the foveal reattachment, so to see if she got rid of the pain or not.
So your advice would be tomorrow you have the same case, you will give the advice to do the same thing?
No, not necessarily. As I just mentioned, if I found upon clinical examination that she might have an ulnar impaction, maybe we would have done things differently. So, but it's clinical examination, and we have to look for the different things. We didn't have an MRI here. You have asked for that several times. So, but now it's clear that it was impossible. So, I think the surgeon did what he could have done at that time.
Maybe last but not least question on the panel from the chat. Lorenzo told me, and after we have unfortunately need to close the session, even it's interesting. And
technical question for the shortening osteotomy. Is there a rule to decide the level of your osteotomy? Because we can see here on your X-ray that the osteotomy is more on the shaft. There is some technique when you're closer to the metaphysis of the ulna. So how do you decide the level of your osteotomy? And does it influence your result of some kind?
I think there are many shortening systems and opinions about shortenings, but this is a diaphyseal sort of.
Because Greg Bain showed that the more proximal you are, the more you will retense the interosseous membrane, so you have a stronger stabilizing effect if you have a GRUJ laxity. So this is something that you can take into account, maybe.
But it'll heal slower.
All right.
I might just add on to that. The distal ulna has a bend in many cases, and it's very easy to shorten a straight bone, and it can be a disaster to try to do it on a bent bone. And I've seen not one case of malrotation, malunion, and then corrective osteotomy. So I feel it's easier to do it where the bone is straight. So normally you just get more proximal. And the second part is you get the stability, as has been mentioned and has been shown. You have more stability and a safer guided shortening. So I personally never do it on a distal area anymore.
Okay. Thank you all for your attention. Thanks you to those who participated virtually. And we'll see you soon at the next Seasonal Risk Forum. Thank you, everyone.
Thank you.
And thank you, Stephen, thank you, Shiab, all the speakers. We would like Lorenzo and me to thank all the participants for your participation to this course, all the experts, Shiab, all our team, Shiab, Stephen, Lucian, Vincente, we have Jan, Asgeri, everyone that helped us a lot. So we have also everyone. You have, tu peux dire quelque chose sur le risk-based camp?
Sur le
risk-based camp qui peuvent regarder?
Yeah, absolutely. If you want to go deeper, you have on the website of the IRCAD and or the IWC, you can go to the risk-based camp. You know, it's a good way to go step by step on all the methods you tried in the course for the basic and the advanced. It's a good way to climb the mountain up to the mastering the wrist arthroscopy technique. And you have the book, you have the ebook where you can also review all the techniques that were shown here. It's free, okay, so you can go there. And hope to see you in the advanced course for the basic one and the master course for the advanced participant. Sure, yeah.
helps. It's really, really a big family. So you're just gathering and belonging to a bigger family now. So welcome.